4 मिनट लगे। पेशेंट है यार हमारी नूर जहां सच बत गई। स्टार्ट हो गया। जूम पे अनम्यूट करके बस स्टार्ट कर। You'll have to just keep on your baby. ठीक है, जब स्टार्ट होगा तो अनम्यूट कर देंगे, ठीक है, और वो हाइड कर देंगे। ये तो स्टार्ट कर देंगे। क्या कर दे स्टार्ट कर दे। अभी मतलब उनसे पूछ के कब करना होता है। मेरे चाहे तो नहीं कर स्टार्ट। इधर ही है ना। खड़े रहो ना। नहीं, मैं खड़ी नहीं रहूँगी। वीडियो बड़ी जाएगा। वीडियो लाने की बात ही नहीं है। अच्छा ठीक है, खड़ी हो जाती है। नहीं बैठना ही है। तो बैठो बैठो, कोई बात नहीं। अपना ही घर है। अपना ही घर है। कर दे। 1 मिनट 2 मिनट 2 मिनट। करने अब तो देखेंगे बस। इसको ज़्यादा स्टार्ट करना है। साइड नहीं करना। A very good evening to everyone, respected teachers and my dear friends. I am Dr. Karthik Gupta, JF 4th semester, going to present a case. A 16-year-old female present to us with blurring of vision in left eye for 2 months, which was sudden in onset, progressive in nature, associated with severe eye pain, redness, and intense headache. Past history. The patient was diagnosed with both eye primary angle closure glaucoma and underwent both eye laser peripheral iridotomy in the nearby hospital. Patient also underwent left eye trabeculectomy with 0.02% mitomycin C under local anesthesia outside. No significant family history was present. No history of trauma was present. Outside records of the patient showing on 2nd August 2021, IOP in right eye was 28 mm Hg and in left eye was 36 mm Hg, for which patient was advised both eye laser peripheral iridotomy with combination of timolol 0.5% and pilocarpine 2% twice a day. And after around 4 weeks, patient was followed up, and on that day, pressure in right eye was 16 mm Hg and left eye pressure was 30 mm Hg, for which right eye same treatment was continued, and in left eye maximum topical medical therapy was advised. And after 2 weeks, patient was again followed up, and pressure in right eye remains 16 mm Hg, and in left eye pressure still remains high, for which both eye same treatment was continued, but additionally tablet acetazolamide 250 mg BD and syrup glycerol 3 teaspoons 6 times per day was advised. And after 2 weeks, patient was again followed up, and pressure in right eye remains 14 mmHg, and in left eye it was 22 mmHg, for which right eye same treatment was continued, but in left eye fornix based trabeculectomy with 0.02% mitomycin C was advised. And patient was again followed up after 10 days, and on follow-up 10th day, the pressure in right eye rise up to 35 mmHg and in left eye 40 mmHg, for which patient was given maximum tolerated medical therapy. And after 10 days, again the pressure dropped down to in right eye 20 mmHg, in left eye 24 mmHg, and maximum.
I think I knew. Zoom वाले controls इस पे.
So what is the diagnosis of the patient? You see that the pressure was high, laser-type hydroxyl was diagnosed. The younger most
nipple. So what was the most likely diagnosis for this patient? This is the outside treatment records. Okay, what was the age of the patient? So is it likely that it is primary angle glaucoma? Unlikely. So any other हमारे पास anterior segment
that will be showing for
okay,
this.
ठीक है. So looks like angular closure glaucoma
Yes.
in a 16-year-old girl.
Okay, it's easy one. On systemic examination.
It is, are you there? If you have started the class, the voice is not clear.
Hello.
So is it audible now?
Audible, but the voice is, as somebody has also written, the voice is not, it's coming a little bit rough. I don't know why.
Systemic examination was within normal limits. No history of any drug or food allergy was present. And on ocular examination, visual acuity in right eye was 6/6, and in left eye it was 6/9, which improves to 6/6 with -1 diopter cylinder, -1 diopter sphere. And on applanation tonometry, pressure in right eye was 14 mmHg and in left eye was 22 mmHg. Both eyes were orthophoric. In the first picture, as you can see, this is a picture of slit lamp showing patent peripheral idiotmy. And in the second picture, and in second picture, as you can see, there is a peripheral iridocorneal touch inferiorly and shallow anterior chamber centrally, and iris and lens in its original place. And in the third picture, as you can see, bleb is moderately elevated, mildly vascular, with no leak and with fibrosis present, which indicates Indiana grading H2, V1, E2, S0. On the gonioscopic examination, in the right eye, angle appears totally closed, as you can see here. And the another picture, this is a picture of left eye showing patent ostium. Showing a patent ostium and angle appears totally closed, as you can see here. Third picture showing, this is a picture of ultrasound biomicroscopy showing
Can you please tell what are the findings of the UBM?
Ma'am, here
No, not you. Let Arpita say. Yes.
Ma'am, in the UVM we can appreciate that the iris insertion is not convex, it's a plateau iris configuration.
No, you have to explain why is it plateau iris. Can you explain?
Ma'am, basically, ma'am, the configuration of the iris insertion, normally it should be slightly convex in the periphery, which is not.
In which cases it is convex in the periphery? In routine cases you find convex iris configuration?
Mainly in PACG patients.
PACG, which type of PACG? Please specify. There are various mechanisms for PACG. So which mechanism of PACG will lead to a convex iris configuration? Pupillary block. So do you find that kind of a picture, convex iris configuration?
No.
So it is little convex in the periphery, but as it is coming to the center, it is flattening, right?
Yes.
So can you explain it better now? What kind of a picture do you see? It's not a very good photograph. Anybody who can explain better, Ananya? So we are given 1 hour for this case. So it is a grilling session for all of us. Because we don't have much to talk about except then assess you guys. So what do you find, what are your observations about the ciliary body, the relationship between the ciliary body and the iris configuration per se? In which cases do you find a peripheral convex iris and then a central flattening? Yes, Arnav? Now you are given a chance.
Originally, this configuration has been described in plateau iris. In gonioscopy, there will be absence of ciliary body recess and there will be a double hump sign which is appreciated on gonioscopy, with the first hump due to the mid-peripheral part of the lens and the second hump due to the peripheral rolling of the iris. But ma'am, in this patient,
Monica, he said on gonioscopy, the absence of the ciliary recess. It's not seen on gonioscopy because you can't see the ciliary body. So can you point out with the cursor where is the absence of the ciliary body here, the recess of the ciliary body? What does he mean by that?
This is absence of
So there should be ideally a space between ciliary body and the posterior part of the iris, which is absent here. Okay, they are abutting each other. It is the ciliary body is almost like pushing the iris up, leading to a plateau iris type of a configuration. So this is plateau iris, S-shaped. So peripherally the iris bends because of the almost like a push-up by the ciliary body. So there is absence of the ciliary sulcus, iridociliary sulcus, this term is called. So this is one of the clues of the plateau iris. So if it is present all around, it is 360 degree plateau iris, but it may be localized to some quadrants. So we have to actually see. So who all is there? Okay, so she, get up please. Can you explain us, one is, she was a 16-year-old girl with PACG, so she has plateau iris. Any other mechanisms in a young girl with PACG? Anybody who can volunteer for this? It's an easy question. Rahul? आप बताओ बेटा. In which case? What is this glaucoma called? Give him the mic, please. So we are asking not about the malignant glaucoma, we are asking about PACG. What are the causes of PACG?
like any inflammation, secondary to the inflammation that can be linked to the.
What is primary? Primary doesn't mean that you are talking about the vitreal pressure or the inflammation. We're not talking about these things. Is genesis of the trabecular meshwork? My God. So anterior segment is genesis and primary ankylosing glaucoma, adult glaucoma, they have anterior segment is genesis. What are you talking about? Sindhuja? Causes of PACG.
Iris configuration.
She told about relative pupillary block. Any other causes? Plateau iris we talked about relative pupillary block. Any other causes that can lead to angle closure in a young patient? Yes?
mechanism which will pull the iris forward, or there is a mechanism which is pushing the iris forward. So there is a mechanism which is pulling the iris forward. So anything like ICE syndrome because it's a young patient.
So these are not the primary causes. These are all secondary causes, which are because of IC is secondary to a viral infection. So it leads to contractibility and the membrane formation. So this doesn't come under PACG. So other causes could be like
Anything pushing it forward.
pseudoplateau. I was kind of a picture where ciliary body is pushing it. Then it could be small eye, nanophthalmos, or a very small eye, more than 20.5 millimeters also. These can also later become angle-closure glaucomas. So you must think of these possibilities when you're looking at, because relative pupillary block per se is very, very uncommon. The cause for relative pupillary block is lens becomes thicker, leading to an anterior segment crowding, which doesn't occur in a young patient. So don't think of relative pupillary block when you're talking about a young patient angle-closure glaucoma. So think of these reasons. Okay,
And on biometry examination, in right eye axial length was 21.70 mm and in left eye it was 21.75 mm, which rules out nanophthalmos. And nanophthalmos cutoff is 20.5 mm. And but still the patient is hypermetropic. Yes. And the anterior chamber depth in right eye was 2.59 mm and in left eye it was 2.80 mm, which was borderline. And in lens thickness in right eye was 3.73 mm and in left eye it was also 3.73 mm, which rules out microspherophakia. And on the fundus picture, in the right eye showing cup disc ratio of 0.7 with inferior notching with bayoneting of vessels, as you can see here, and which corroborates to the Humphreys visual field examination showing superior nasal step. And in left eye fundus picture showing cup disc ratio of 0.7 with inferior thinning with inferior notching, which corroborates to the Humphreys visual field examination with showing superior arched scotoma extending up to periphery. This is a picture of IOL master. This I have already explained in
what's the next slide?
Now, what is our provisional diagnosis? Our provisional diagnosis was both eye primary angle closure glaucoma in young with left eye operated fornix-based trabeculectomy with retracted conjunctiva with query early bleb leak with fibrosis with inferior iridocorneal touch. Now, further management will be explained by Dr. Akhilesh.
So Rakesh, can you summarize what had happened in this case in your own language? Your own understanding of what had happened?
Ma'am, patient basically had blurring of vision, so this, she went to local hospital where pressures were high and they performed peripheral iridotomy in both the eyes. Then in right eye the pressure was controlled, but in left eye the pressure was still increased and various medications were given, and also in left eye trabeculectomy was done. But even after that there was no control of the pressure in the left eye, and on examination we found that there is iridocorneal touch and
Okay. So it was totally AC was flat inferiorly. Touch is a different term. It was almost like a flat AC inferiorly.
flat AC was there, and on gonioscopy and
So
UPM.
why did the AC go flat? That is my question. Post trabeculectomy, why do you think that there was a AC shallow or flat?
Ma'am, because as the patient was hypermetropic, so and there was the AC depth was less. There, one cause can be malignant glaucoma.
He's just written it in the diagnosis. Query early bleb leak. What do you understand by this? With bleb fibrosis. Shivani, can you tell? तुम्हारे पेट था ना रावी पे?
मैम अर्ली ब्लैक लीक because of that जो cause of that
AC shallow.
Initial leak had occurred, but now there is fibrosis, and because of the leak, there is no. There should be subconjunctival fluid collection for the bleb to remain functional, which was not there. All the fluid went out of the conjunctiva. Okay, that led to bleb fibrosis, and therefore the high pressure is there. So, okay, Divya. So, PI did not work in this case. So what are the causes where PI may not work in a case of angle closure glaucoma? So you do PI, you know that it is not successful in all the cases. So which are the scenarios where PI will not work? And you will have to go on to the trabeculectomy. Anybody who knows?
If in the periphery the angles are closed, even we do PI in the peripheral 1/3 and middle 2/3 junction of at the iris in the deepest trap. So it is somewhat more towards the center with. It is more in the central region of the cornea when we compare it to the angle. So in case of a creeping angle closure or a plateau iris configuration, there will be no space of echoes to go into the angle despite a patent PI.
So creeping angle closure term we do not use. It is basically to just tell you that the patient is asymptomatic despite having chronically progressive angle closure glaucoma. So this is more like a subjective term that maybe he is having intermittent attacks without knowing. We don't know. So the condition in chronic PACG where it will not relieve it is the condition where chronic PAS have formed. Okay. So central 1/3 में किया है, peripheral 1/3 इस सब का कोई फंडा नहीं है. अगर angle open होना है, अगर there is a space with PI, it will push the fluid anteriorly and if it is not a synechial angle closure, it will open. But if there is synechial, then the PI will not work. This is in chronic pupillary block glaucoma. Okay. Other is plateau iris will not be relieved. Any other condition where PI will not work? Okay. Any other cause of angle closure glaucoma other than the malignant glaucoma, lens-induced mechanism, any cause because of the choroidal effusions? In any of these, you have to eliminate the primary cause. So PI will work only basically in cases of relative pupillary block. PI is the treatment for relative pupillary block. In other cases, other scenarios of primary or secondary angle closure glaucomas, a PI has no role. Or in chronic angle closure glaucomas where PAS is formed, more than 270 degrees of the angle, PI then again will not work. Okay, let's come to the management now.
Good evening, everyone. This is Akhilesh. I'll be discussing how the patient was managed in our hospital. On presentation, based on the patient's history, examination, and investigations, we diagnosed the patient as both eye primary angle closure glaucoma in young. Because we diagnosed as angle closure because on gonioscopy angles were closed, and glaucoma because there were obvious visual field defects in the Humphrey's visual field. And young we have added because the patient is 15 years old with right eye laser PI which has been done and it is patent, and left eye outside operated trabeculectomy. Now the patient is having inferior iridocorneal touch with IIOP. So basically the patient is having left eye AC shallow with IIOP, and now when the patient was presented, we initially went with there is a pre-op picture of the right eye of the pre-op picture of the left eye of the patient. Here you can see the inferior iridocorneal touch of the patient. Here actually AC is shallow both circumferentially as well as in the centrally, but it is more in the circumferentially, and inferiorly we can see the iridocorneal touch. And the patient's AC formation was done on 26/10/2021 with sodium hyaluronate 1.4%. On post-op, the both eye IOP was 12 and vision was 6/6. This is a post-op picture of the patient. As you can see that AC has been formed in the patient, but still the AC is towards the shallower side. And the patient was discharged, and on 1 week.
So, Hemant, so what is this suggestive of a shallow AC post-trap?
With a little higher IOP, shallow AC with high IOP post-trap. What could these be because of? You've not had a glaucoma posting with it? Sit down. Papa, you can tell.
Ma'am,
Give her mic, please.
post-op shallow AC can be
With high IOP. This is
with
the
high IOP
combination.
can be due to pupillary block mechanism, malignant glaucoma.
So post-trap, do you find pupillary block?
Yes, ma'am. In case if the iridectomy which was made was small or it has been
If it is non-patent. If
non-patent.
it is non-patent, only then. If the iridectomy is not patent, it's blocked by some blood, fibrin or anything, or it was lamellar cut during the surgery. Then it can happen, otherwise no. Okay, then?
And ma'am, otherwise it can be due to malignant glaucoma or suprachoroidal hemorrhage. The
Okay.
suprachoroidal hemorrhage will be more serious.
It will lead to loss in vision. Unlike malignant glaucoma, where the IOP is borderline high and the corneal edema has not yet set in, then the vision will not drop. So this is how you can differentiate. Of course, you will have to look at the fundus and all. So this looks like malignant glaucoma. Okay. And plateau iris is a risk factor for malignant glaucoma. You must keep this in mind. Okay, sit down.
After AC formation, the patient was discharged and after 1 week post-op, the vision was in right eye was 6/9 and 6/6 in the left eye. And now we can see that the left eye IOP has been controlled and left eye IOP is 15 and right eye now the IOP was 35. So even though left eye AC was formed and even though it was in the shallower side, the right eye IOP was 35. So we went for conservative management for the left eye, medical management for the left eye from now, and we underwent right eye trabeculectomy, which was done on 13/11/2021. On 1 week post-op of the right eye trabeculectomy, now the patient is operated both eye trabeculectomy, right outside left eye. Okay. Now the patient is operated both eye trabeculectomy, left eye operated outside, and right eye trabeculectomy done here. So on 1 week post-op,
In the fellow eye, if one eye has already developed malignant glaucoma.
ma'am, there is a 100% risk in of developing malignant glaucoma in one eye in the other eye if the other eye has been
Especially if that eye has high risk factors like plateau iris.
plateau iris.
Right?
Yes,
So,
ma'am.
any other management that you could have thought of in the right eye after left eye has gone into malignant glaucoma post trabeculectomy? Would you still think of doing trabeculectomy in the right eye? What else could you have done, Monica? You can answer this question. You want to try it, Akhilesh? At all?
Ma'am, initially I could have gone with medical management of the right eye.
That's failed. Apparently, this is not working.
Ma'am, initially we had put the patient only on anti-glaucoma medications. Now I can put the patient on cycloplegic eye ointment atropine 1%.
Probably we could have kept on atropine that could have worked for this
Yes, ma'am.
patient pre-operatively. Anything else? If surgical management is to be done, what could be done?
Ma'am, laser procedure.
Is it to make comment on?
Ma'am, we have done anterior vitrectomy, but the patient is a phakic patient, so
Right.
Right eye. बोल रहे हैं कि trap की जगह हम क्या कर सकते हैं
Right
इस patient में?
cataract, the clear lens extraction, making the patient pseudophakic and making a unicameral continuate, मतलब anterior chamber or posterior chamber.
That can also be done. So these surgical choices, they all depend on the surgeon's preference. But the trap, we for sure know that the patient will land up into the malignant glaucoma. So before that, we can actually go for lens extraction with PCC if
PCC.
required on table. Because if the patient is to develop malignant glaucoma, it will occur on table while we are doing either cataract or trabeculectomy. But after trabeculectomy, it is difficult if the patient is phakic to manage the malignant glaucoma. So you can also try in these cases if Timox is working, systemic management is working, you can try for cataract surgery with anterior vitrectomy in these cases.
Yes,
when you know already that this might develop into malignant glaucoma. ठीक है, फिर हमने क्या किया?
So on 1 week post-op of right eye trab, the IOP of both eyes were 24 and 26 and anti-segment examination of the right eye and the left eye. Now here we can see that both the eyes AC are in the shallower side and both eye IOP is high and UBM of the and in the UBM we can make that there is a anterior rotation of the ciliary process and the ciliary process has become parallel to the iris and there is forward displacement of the iris lens diaphragm and the ciliary sulcus which is there which has been absent here. So by these findings of AC shallow and IIOP with even and angle is closed and PI even though it is patent still the pressures are not controlled and UBM findings the patient was diagnosed as both eye malignant glaucoma and the patient was put on hyperosmotic agents with eye ointment atropine QID. And there was an attempt was made to form the both eye AC formation was done on 1 week post-op with sodium hyaluronate 1.4%, but still on 1 week post-op the pressures were high in the left eye of 26 mm mercury. So we underwent left eye anterior vitrectomy and the patient was kept on medical management. This was anterior vitrectomy which was done for the patient. Still we can see that in the post-op the AC is still in the shallower side. Yes, ma'am. The anti-vitrectomy was done in a phakic eye.
So, who all is left? Shaka, तुम्हारे साथ कौन बैठा है? हाँ, get up. What's your name? Akshara. Akshara, can you tell why did this surgery fail? The patient still continued to have high IOP after anterior vitrectomy. So this is malignant glaucoma, and most likely we need to do anterior vitrectomy, which we did in this patient.
Maybe we were not able to completely take the anterior hyaloid phase.
Okay, why is it important to rupture the anterior hyaloid phase?
So that the aqueous misdirection is solved. If they break the anterior hyaloid phase, then only the aqueous will not. There will be a passage for the aqueous to move forward.
How? Through the lens? The aqueous will move through the lens?
In the capsule.
The capsule से कैसे करेगा? In a
Zonules के through.
zonules के through? After you break this thing?
After we break the zonules, they have to break the zonules and the.
So you are saying that with anterior vitrectomy in a phakic eye, you have to first cut the anterior hyaloid also and break the zonules also. Lens will fall down? No. How do you break the zonules? How do you do that?
Iridocapsulohyalidectomy.
Iridocapsulohyalidotomy. So how do you do that in a phakic eye? That's my question. How can you remove the capsule in a phakic eye? Who is sitting next to you? Himani. So what did we not do in this case? Actually, she's right. So we have to do lens extraction. Any procedure for malignant glaucoma cannot be done without taking the lens out. So that has to be taken out to do capsular procedure. Or if it is pseudophakic, we can also go for any conservative management in a pseudophakic eye with malignant glaucoma before taking for vitrectomy.
India cap.
Anti-yak cap with hyalidotomy. So that can also be tried. But without that, this procedure is of no use. Okay, sit down. So what we learned from this case कि हमें फायदा नहीं हुआ phakic eye में सिर्फ anterior vitrectomy करने का. Okay, next.
So we can see in the post-op of anti-vitrectomy, AC was still in the shallower side. And on 21/12/2021, the patient underwent left eye clear lens extraction with posterior capsulotomy, with hyalidectomy, with anterior vitrectomy. So after 1 week post-op, we can see that the pressure was controlled. So this is first initially the left eye anterior vitrectomy was done. The surgery was done in 3 settings. First, single port transconjunctival anterior vitrectomy was done, followed by clear lens extraction, which was followed by anterior vitrectomy, hyalidectomy with posterior capsulotomy. And this is the post-op picture of the patient, and we can see that the AC is well formed now, and the IOP of the patient in the 1 week post-op was 16 mm. So on 4/1/2022, the patient underwent right eye clear lens extraction with posterior capsulotomy, with hyalidectomy, with anterior vitrectomy.
Okay.
So this is the right eye post-op, and this is the left eye post-op of the patient now. Both the eyes AC is formed, well formed, and IOP is controlled. Now here is a surgical video of the procedure by Dr. Shikama. So
This is for the which eye? Right eye, right?
this is the right eye surgery. Before here important thing which we have to keep in mind before starting the surgery is the bleb. So
Keep the video on so that it keeps running and
Okay.
you keep talking. Yes.
So here bleb should not be MVR entry should be placed away from the bleb. And here initially you can see that it was very difficult for the to do MVR entries because AC was very shallow. Initial steps, ear artery dye is done.
Iris is also collapsing to
Iris
the
is
port wound,
yes.
which is unusual otherwise. So it suggests shallow AC with high IOP.
And here you can see that when dye is
Keep the video running.
okay. Here you can see that when the dye is injected, the bleb takes the dye. That means that the bleb is well functioning.
Despite that, the IOP is high.
IOP is high. Now, then the single port anterior vitrectomy.
It was done because the AC was not allowing us to do the capsular access. So we did a vitrectomy first so that it somehow goes back a little bit, and then we can go about with the capsular access.
So after anterior vitrectomy, now the AC is well formed, and we have gone ahead with anterior capsular access, followed by clear lens extraction.
So this is a single port vitrectomy where you can see under visualization and go about with the cutting with the limbal infusion. We're not putting the infusion through the posterior cavity, but through the limbal infusion we're giving the infusion. Now you can see AC is so well formed at this stage. Okay. आगे कर दो.
Yes, ma'am.
Lens is put.
Lens was put in the bag.
AC is still shallow now again. So we have not done a definitive treatment.
Now, here irrigation cannula is put in the AC, and with the cutter we have done the posterior capsulotomy.
Can you see here? Posterior capsulotomy.
Yes, ma'am.
This is the margin. So you have to make sure that you do right in the center. It is a weak capsule. It's not fibrosed. So you do right in the center, make it small, and then after doing capsulotomy, you can do the anterior hyalotomy, which is already done. Once you have entered that plane of the capsule through the pars plana, that means you have already broken the anterior hyaloid. Then you can do a little bit more vitrectomy or the sequestered aqueous. You can continue with the video. Okay, and this is the final stage. You can see AC is well formed, right?
So post-op status, the vision was 6/6 in
How
both.
deep the AC is now, which was never so deep. Okay.
So in both the eyes, IOP was 16 and 16, and vision was 6/6 in both eyes. Both eye AC is well formed. The patient was kept on eye ointment atropine 1% HS, and patient was put on prednisone, which was tapered weekly. Thank you. The case will be discussed by Dr. Monica now.
Good evening, everyone. So the summary of a case is both eye PACG in young patient with plateau iris with operated trab. Post-trab, there was recurring shallow anterior chamber with high IOP despite of filtering bleb suggestive of malignant glaucoma. These are the pictures of UBM. This is a pre-op picture in which it was a plateau iris configuration, and after the trabeculectomy, it turned into the malignant glaucoma. We can see that there is an anterior rotation of the ciliary body with forward rotation of the ciliary process touching the equator of the lens, and the angle is totally closed here. So the management was done both eye clear lens extraction with anterior vitrectomy, with hyalodectomy, with posterior capsulotomy. So coming on the malignant glaucoma, the term was given by von Graffe in 1869, where he described that malignant glaucoma as a shallowing of axial anterior chamber, both central as well as peripheral, in association with increased IOP with normal posterior segment anatomy despite patent iridectomy. Aqueous misdirection is the diagnosis of exclusion and requires exclusion of other clinical entities such as choroidal hemorrhage, choroidal effusion, and pupillary block. There are many terms for malignant glaucoma: ciliary block glaucoma, lens block glaucoma, and ciliovitreal block glaucoma, which I will discuss later. The prevalence is 0.4% to 6% in incisional surgeries for primary angle closure glaucoma. It can occur after laser iridotomy, phacoemulsification, cyclophotocoagulation, ND-YAG cap. It may occur in phakic, pseudophakic, or aphakic eyes. What are the predisposing?
Presentation of malignant glaucoma. जो इसमें लिखा नहीं है यहाँ पर. Incisional surgery लिखा है. Post-trab.
Sure.
So most common is trabeculectomy. Okay, because you are making a filtering bleb. The ostium is patent. That shallowing of the AC is predisposing it. Okay.
So what are the predisposing factors? Axial hyperopia, as a patient was having. Nanophthalmos, chronic angle closure with plateau iris configuration, our patient was having. History of malignant glaucoma in affected eye. This was also in our patient. So what are the predisposing anatomical features? Incorrect anatomical relationship which leads to disruption in the direction of aqueous humor flow. The place of increased resistance may be located at the level of iris lens, ciliary lens, iris hyaloid, and ciliary hyaloid block. Structure that are particularly related to the development of malignant glaucoma, sclera, lens, choroid, and vitreous body. So in cases of nanophthalmos or plateau iris or in PACG in young patients, how does sclera contributes to these? There is a thick sclera in these patients which leads to partial stenosis of the vortex vein, impairing normal venous flow, and there is an overfilling of the choroid. And in these patients also there is a disproportion between the lens volume and the volume of the entire eyeball. Due to the lobular structure of the choroid, there is a tendency of accumulation of fluid that leads to the overfilling of the choroid. There are optically clear areas in the vitreous that act as a reservoir for aqueous humor trapped in its gel structure. In aphakic eyes, the anterior surface of the vitreous body directly adhere to the ciliary process. This is known as ciliovitreal block glaucoma. There are multiple pathogenesis given behind the malignant glaucoma, but still the pathogenesis is very unclear. And there are some popular theories which I am explaining. First theory was given by Schaffer and Hoskin in 1954, in which he explained there is a posterior diversion of the aqueous leading to the forward movement of the vitreous gel, which carry iris and the lens forward, leading to the angle closure and leading to the high IOP. Chandler and Grant in 1951 said that when there is a laxity of lens volutes along with the increased vitreous pressure, that leads to the direct lens block. As we can see here, the aqueous humor is directed posteriorly, and the vitreous gel moves forward, and the lens zonules are weak. All these things carry anterior iris lens diaphragm forward, leading to the closure of the angle. So one of the most popular studies given by Quigley in 2003. He explained that whenever there is a choroidal expansion, there is a increase in the absolute IOP of the eyeball, and there generates a pressure difference between the posterior segment and the anterior segment. The pressure in the posterior segment is more than the anterior segment. That leads to the forward movement of the vitreous gel, leading to the forward movement of the iris lens diaphragm and closure of the angle. Normally, there is some aqueous humor directed posteriorly in normal eyes also, but the anterior hyaloid phase has a tendency, it's a permeable to aqueous humor. From here, the aqueous humor seeps out. But in cases of non-ophthalmos or in PACG patients, in young patients, due to the lens thickness, the lens is very thick, so this diffusion area is very less. So, and anterior hyaloid phase is also less permeable. So there is a decreased conductivity of aqueous across the vitreous. So whatever be the pathogenesis, the aqueous is directed posteriorly, increasing the positive vitreous pressure, making the iris lens diaphragm moving the forward, and making anterior chamber flat and increasing the IOP. So there is a misdirected aqueous leading to ciliovitreal adhesions, and there is a thickened hyaloid. In these patients, there is a thickened hyaloid that leads to the diffusion of the aqueous very less. So can we consider iris configuration a predictor for malignant glaucoma? Yes, we can. There was a study given by Tiago et al. They said that is preoperative ciliary body and iris anatomical configuration a predictor for malignant glaucoma development? Identification of PIC by ultrasound biomicroscopy should be considered as a possible predictor of postoperative malignant glaucoma development. There was 85% in their study. There was 85% eyes having plateau iris configuration.
These all developed malignant glaucoma, and of that malignant glaucoma cohort, 85% had plateau iris. So you can see how likely plateau iris patients may be to develop malignant glaucoma.
How can malignant glaucoma be classified? Classic malignant glaucoma occurs in phakic, aphakic, and pseudophakic eyes. Occurrence is independent of the type of surgery and preoperative IOP. Timing is variable. It can occur at POD1, at months, or after years. The pathogenesis behind is partial or total closure of the drainage angle. Axial hypermetropia is associated with high risk. Non-phakic malignant glaucoma or pseudophakic malignant glaucoma develops in patient after cataract extraction. It can occur in eyes with or without glaucoma. Spontaneous malignant glaucoma, very rare, occurs without antecedent eye surgery or myotics, mostly bilateral. Hyperopic females are highly associated. So our patient was of spontaneous malignant glaucoma. Since
the pressures were very high, we may postulate that it could be a pre-operative case of malignant glaucoma also, because the risk factors were there, but we're not sure. So these cases, we believe, this is our hypothesis, we have no concrete evidence to this, so we cannot say for surety. But these cases, as soon as you make a paracentesis for any surgery, they will develop malignant glaucoma on the table. So possibly they have underlying malignant glaucoma, which is shielded because there is no exit wound. Okay.
So the clinical presentation of our case was that there was an increased IOP. There was shallowing of peripheral as well as central anterior chamber with patent iridectomy. There was no decrease of IOP in spite of conventional anti-glaucoma treatment. Patient was given multiple attempts for AC reformation, still the anterior chamber remained shallow. So what investigation can we do? Ultrasonography, biometry, anterior segment OCT, ultrasound biomicroscopy.
One of these investigations on the fourth
one will you choose, Hemant? For a case of malignant glaucoma, if you are given these 4 choices and you have to choose one investigation that you would need to definitely diagnose it, which one would you choose? Yes. So UBM is the definitive investigation of choice.
So we can see here there is anterior rotation of the ciliary process touching to the lens equator. There is iris lens diaphragm is moved forward, and there is entire AC shadow.
The central AC is shallow, the peripheral AC is shallow, everything has moved forward. This is malignant glaucoma. Unlike pupillary block glaucoma where the central AC will be deep, unlike plateau iris where only the peripheral part of the AC would be shallow. So malignant glaucoma is everything shallow. So it is the most recalcitrant. But if you do the management properly, these patients have very good vision. So you should know what their condition is and treat accordingly.
So coming to the differential diagnosis, shallow anterior chamber, matlab what? Okay. So there are the 4 differential diagnoses: plateau iris, aqueous mist with the shallow AC and high IOP. There are 4 differential diagnoses: plateau iris, aqueous mist direction, pupillary block, and suprachoroidal hemorrhage. So this clinical picture of we can see here कि anterior chamber depth is of Von Herrick grade 2. Anterior chamber is shallow, and in this is the UBM picture. We can see here when there is a anterior rotation of the ciliary processes. So we
rotation of the ciliary process in plateau iris. You can see there is absent iridociliary sulcus, and you can see that there is the iris is S-shaped. There is a narrow opening of the angle which is still present. There are no synechial closure. So this is S-shaped configuration of the iris with shallow anterior chamber and absent iridociliary sulcus. This is plateau iris, nothing else. Okay.
In aqueous mist direction,
and PI will not relieve it. So these are the diagnostic features of plateau iris.
Aqueous mist direction, central and peripheral AC shallow. We can see on the UBM. And
okay.
This is a plateau iris, pupillary block. We can see here that the peripheral iris is, peripheral anterior chamber is Von Herrick grade 1, whereas central is very well formed. We can see on the ASOCT, these are the iris bombays.
So this could be because of iris bombay, or it could be like relative pupillary block only. This is called the over the mount configuration. Yes, so if you manipulate, you will be able to see the angle structures if there is no synechial angle closure. Okay. So this is how you should be able to differentiate on slit lamp or gonioscopy what is the condition. Okay, suprachoroidal hemorrhage is a different entity in itself, but the other 3 conditions, these are the diagnostic dilemmas, and you must be able to differentiate all these 3 because the management differs. For example, pupillary block, you would like to give pilocarpine, but pilocarpine is an absolutely contraindication for aqueous mist direction. So unless you diagnose, you will not be able to treat properly. Okay.
This is a pupillary block.
This configuration is also very important telltale sign.
Yes, ma'am. So how can we manage this patient? There are 3 ways by which we can manage the patient. One acting on the ciliary process, other acting on the anterior hyaloid phase, and the third one is on the vitreous. So acting on the ciliary body, we can give the cycloplegia. The cycloplegia relaxes the ciliary body, contracts the zonules, and pulls the iris lens diaphragm backwards. So the anterior chamber can be formed and angles can be opened.
The main thing is that the aqueous produced by the ciliary body is pushed backwards. So cycloplegia will help in rotation of the ciliary body back to its original place so that the aqueous is not misdirected posteriorly. Additionally, it will also help in deepening the anterior chamber, but the main effect of cycloplegic will be to relax the ciliary body and to bring it back to its original position so that the aqueous doesn't go back but in front. Okay. So cycloplegic is a very important step in management, and we tend to give cycloplegics long lasting. Even after vitrectomy surgery, we tend to just relax the ciliary body at its own place. So atropical HS is prescribed for lifelong in these patients unless the patient develops some allergy to it. Okay.
We can also give aqueous suppressant. Lasers can be done at the level of the ciliary body, transscleral photocoagulation. There is a coagulative necrosis, ischemia of the ciliary process leading to the disruption of the adhesions between the ciliary process and the anterior hyaloid, so that the ciliary processes can go to towards its normal procedure. But this is a very destructive procedure, so normally this procedure is not done in our patient as the vision was very good in our patient. And the other laser we can do.
Can be done by endoscopic photocoagulation. So this is done only when we have no other way left. So maybe in eyes with poor vision, we can do endoscopic photocoagulation or DLCP to relax the ciliary body. But this is not done in eyes with useful vision. Okay.
Other laser can be done as argon laser.
Next, vitreous phase or इसका क्या कह रहे हो highlight का?
This should be done in the pseudophakic patient. So we can do the anterior hyalotomy with posterior capsulotomy. So by this making this opening, the aqueous which is accumulated in the
How do you do ND and hyalotomy?
मतलब procedure.
How do you do it? Can you see anterior hyaloid? Has anybody seen anterior hyaloid phase
back.
on the slit lamp?
क्या बोलते हैं उसको? Anterior
So
and
there is a
posterior.
membrane that you can see post after the capsule.
Offset.
It is easily visible if it is intact.
Posterior offset.
Especially if the lens is very clear. So try seeing all these things. We should be able to see in young patients very intact anterior hyaloid phase after you see the posterior capsule on slit lamp. So that membrane you have to perforate. So it will be seen on slit view in eyes with clear lenses, but not on diffuse illumination that you use for ND-YAG cap. So it's just that after ND-YAG cap, you fire the shots posterior to it.
Posterior
Because you
offset.
can't actually differentiate on the diffuse illumination where is the anterior hyaloid, but on slit it is easily visible. So once you see it, you will be able to recognize it. Next time everybody will try and see. Okay.
So coming on the medical therapy, cycloplegia, aqueous suppressant, osmotic agents and steroid. Laser therapy, transscleral cyclodiode photocoagulation, argon laser, ND-YAG cap with hyalotomy in pseudophakic patients. Surgical therapy. If the patient is resistant to medical as well as laser therapy, we should approach towards the surgical therapy. In surgical therapy, anterior vitrectomy with hyalozonular iridectomy. In this, what we do, we after making
What Akshara was talking about, so can you explain her what is the procedure?
after making 3 ports pars plana vitrectomy, the vitrector is used to break the
Images?
sorry ma'am.
Yes, sir, images.
Yes ma'am.
Show that.
What we do in these case, we make a 3-port pars plana vitrectomy, and with the vitrectomy cutter, we break the anterior hyaloid.
So it's only at one clock at Akshara that you do the zonulectomy for that aqueous to percolate anteriorly, but then again it is not so successful. It leads to a lot of recurrence, which we usually don't see with capsulotomies. And plus it is a blind procedure if you are doing from anterior to posterior. People attempt it from the iridectomy of the crab side, and then they go down from there with the vitrector vertically directed. So it is a blind procedure. I have not done it ever, and it is and success rate is also not so good as compared to the other procedure which we have been doing regularly for the last 3 years with 100% success outcomes, so no recurrence.
In these patients, the recurrence occurs because there is the opening which is made here in the anterior hyaloid or in the zonular. The vitreous get blocks in this, and this opening get closed, and there is a more chances to the trauma to the lens also. So what was the conclusion in their study? In treatment-resistant malignant glaucoma, vitrectomy combined with HZI should be considered performed to ensure communication between the anterior chamber and the vitreous cavity.
So this is the key word, that we want to create a conduit between the posterior and the anterior chamber. That the fluid movement should be free between the two chambers. Only then you will be able to resolve malignant glaucoma. If you do only vitrectomy, some people advocate the use of pars plana vitrectomy or core vitrectomy. So now do you think that these procedures will work? Literature states that 4 vitrectomy should be done, and people refer to the vitreoretinal surgeons who will do entire vitrectomy. Then also you will not be able to relieve it despite eating up the entire vitreous, because aqueous will still be posteriorly directed, and there will be no space for aqueous to come anteriorly. So unless you break that barrier between the posterior and the anterior chamber, no vitrectomy will help. So this is the key home message today, that you have to break the anterior posterior barrier by either capsulotomy or hyalotomy with iridectomy. Okay.
This was a study done by our center, Dr. Shikha Gupta and et al. Single port transconjunctival vitrectomy for malignant glaucoma. So what we can see here, there is a misdirection of the aqueous in the posterior cavity, in the vitreous cavity, sorry. There is a forward movement of the iris lens diaphragm with flat anterior chamber, and there is a iridocorneal touch. So what we did, first we break down the anterior iridocorneal contacts with the 27.
This is called syneculisis.
Syneculisis. And after that, the clear lens, the patient was made pseudophakic and anterior chamber was maintained. Using the anterior vitrector, the anterior hyaloid was broken.
Pars plana retractor. Anterior retractor is when you are entering to the corneal incision. When you are entering to the, you make a pars plana entry. So this is a pars plana retractomy with a single port. Okay.
The anterior hyaloid was broken down and the posterior capsulotomy was done. So we can see here there is a direct communication between the posterior segment and the anterior segment, and the aqueous flow from the posterior to the anterior. So in the pre-op picture we can see here how the anterior chamber is shallowed, the von Herrick grade 1, and after the post-op the von Herrick grade 3 is there. Anterior chamber is well formed. So coming to the conclusion, single port 23 or 24 or 25 gauze transconjunctival pars plana vitrectomy and posterior capsulotomy in pseudophakic eyes or vitrectomy after cataract surgery in phakic eyes was safe and effective for treatment of malignant glaucoma with no recurrence seen in conjunction with long-term cycloplegics.
So you have to continue giving atropine. Okay.
The main aim of the surgery is, as the ma'am said, we have to disrupt the hyaloid phase.
Is
And
there any new information in this slide?
no, ma'am.
Just then go to the next slide. So these were different mechanisms: zonilo-iridectomy or transconjunctival vitrectomy with capsulotomy and hyalotomy, and NDER cap with hyalotomy in conservative management in early cases of malignant glaucoma that may get resolved. So this is the key home message that this is how we should proceed. But the first step that you must be doing when you see a case of malignant glaucoma is start the patient on atropine.
When there is a malignant glaucoma in one eye, there are 100% chances of malignant glaucoma in the fellow eye. So what are the prophylactic measures which can be done? We have to do LPI for occludable angle.
Just to make sure that it is something else.
Yes, ma'am. Cessation of the myotic drops. Prolonged use of atropine 1% before and after surgery.
This before is not written anywhere. So
Huh.
this is to be taken with a pinch of salt. But what we think that we should start it pre-operatively only, so that the CVD body remains relaxed during the surgery and doesn't come forward. Okay. So this we need to study again. Okay.
So whenever we are going for the cataract surgery or for the filtering surgery, avoidance of anterior chamber shallowing is very important in the intraoperative as well as in the post-operative period.
But if you find in any of your cases during cataract surgery or any of the cases when you're having difficulty in maintaining the anterior chamber despite putting everything inside, we should suspect that malignant glaucoma has occurred, especially if the patient is pre-operative known case of glaucoma or shallow AC pre-operative. So you should always try to put pinky properly, उसको अच्छे से massage दो, IOP कम होना चाहिए on table. So high IOP in the case of angle closure is also a risk factor. So IOP should be lowered. And if you find difficulty in maintaining the AC, you should suspect either suprachoroidal or malignant glaucoma. So you should call your CA who is adept at doing. First, you should do vitrectomy and then proceed with the cataract surgery to deepen your chamber and then maybe do the complete vitrectomy later on in a pseudophakic status. Okay.
It can be done by using anterior chamber viscoelastic, pre-placed releasable sutures and tight scleral flap sutures. So coming on the conclusion, anterior vitrectomy with zonulectomy and iridectomy have been proposed for malignant glaucoma, which is a high risk of recurrence and complication, as well as it is a blind procedure. 3 post pars plana vitrectomy also has a high risk for recurrence and complication. This probably reflects the lack of effective removal of the anterior hyaloid in phakic eyes because of the risk of lens damage and subsequent cataract formation. Single port 23 or 25 gauze transconjunctival pars plana vitrectomy and posterior capsulotomy in pseudophakic eyes or vitrectomy after cataract surgery in phakic eye is safe and effective for treatment of malignant glaucoma with no recurrence seen in conjunction with long-term cycloplesias. The most advantage of this is that it can be done by anterior segment surgeon also.
So any questions are welcome. Very nicely presented, Monica. We've covered almost everything.
Thank you, ma'am.
Anybody who has any question on chat box, please. If somebody posting some question, otherwise we are done for the day. PPL, what is more destructive? We got to decide everything. PPL you can do if you are able to put the lens onto the anterior capsule. So, and of course, PPL would be done for posterior segment surgery. Okay. Thank you, everyone.
Thank you.
Thank you, presenters.
Thank you, ma'am.
तो बच्चों के मैं नहीं आना मैं नहीं आना क्लास में वो तो क्वेश्चन ही हम समझ रहे थे क्वेश्चन ही नहीं समझ रहे